The role of neuroplasticity in complex post-traumatic stress disorder and its implications for treatment and recovery. Developments in neuroscience have illuminated the role of neuroplasticity in the understanding of trauma in the brain. Avril 20. Plasticity plays a critical role in both adaptive and maladaptive response to trauma. In complex post-traumatic stress disorder, individuals may experience recurrent trauma-related memories, avoidance behavior, and heightened arousals, leading to decreased prefrontal cortex and activity, reduced hippocampal volume, and increased amygdala activity. These changes disrupt fear perception, decision-making, memory, and emotional regulation, Avril et al. 2021. Furthermore, Crystal et al. 2017 note that neurotransmitters are synthesized in the axon and stored in the vesicles, subsequently binding to postsynaptic receptors upon release. In PTSD patients, repeated stress can cause synaptic disconnection, damaging white matter axons and resulting in neurotransmitter imbalances. Effective treatments aims to restore these levels and improve brain function, G et al. 2023. Patients with a history of repeated trauma are more vulnerable to C-PTSD due to the re-traumatization affecting neuroplasticity, Meekinen Viggers et al. 2019. Stevens et al. 2013 noted significant neuroplastic changes in cases of traumatic brain injury and how they are very similar to that of those in PTSD. Hull 22 emphasise that while C-PTSD is linked to psychological trauma and traumatic brain injury as a result of a physical brain damage, both conditions impair similar aspects of neuroplasticity. Bremner 2006 underscored the importance of the mind-body connection, noting that dysregulation of the adrenal system can lead to physical symptoms like tachycardia and hypertension. In C-PTSD, chronic stress disrupts the epinephrine system, contributing to the hypervigilance and anxiety triggers, that is the body's fight and flight response, Franco 2021. Smouthwick et al. 2005 and Pittman et al. 2012 explore how the adrenic neurotransmitter dysregulation interacts with the HPA axis and contributes to PTSD symptoms. Neuroplasticity enables the brain to recover and adapt after trauma, which is essential for diagnosing and monitoring treatment. Screening tools for assessing PTSD and C-PTSD include the International Trauma Questionnaire, the Post-Traumatic Stress Disorder Checklist for DSM-5, the Child Revised Impact of Event Scale CRIES, and the PTSD Symptom Tracker. These instruments help evaluate symptoms and track treatment effectiveness, Franco 2021. The ICD-11 recognizes the influence of neuroplasticity linked to genetic and environmental factors and how these shape the brain's response to trauma and the increased risk in developing C-PTSD. Individuals with psychological vulnerability may experience more pronounced neuroplastic changes, leading to more severe symptoms, and their neuroplasticity can already be compromised. Trauma can lead to maladaptive neuroplasticity, causing hypervigilance, anxiety, and fear. The prefrontal cortex often shows reduced activity, and in the hippocampus may atrophy, resulting in memory issues and difficulties distinguishing past from present experiences. The amygdala may also become overactive. Recovery involves the brain's capacity to reorganize by forming new neural connections. Tailoring treatment methods to individuals' neurobiological profiles greatly enhances their effectiveness. By harnessing neuroplasticity, therapeutic strategies can assist individuals in processing and integrating traumatic memories, thereby diminishing the negative impact of trauma during challenging situations. This approach engages critical brain regions, particularly the prefrontal cortex and amygdala, which are essential for emotional regulation, G et al. 2023. Enhancing neuroplasticity through pharmacotherapy can significantly support recovery from PTSD. Selective serotonin reuptake inhibitors, SSRIs, promote neurogenesis and synaptic plasticity, improving treatment outcomes. These medications effectively alleviate symptoms such as anxiety, depression, and hyperarousal, with options like fluoxetine, paroxetine, and venlafaxine showing notable benefits. For optimal results, pharmacotherapy is most effective when combined with psychotherapy. Pittman et al. 2012. J et al. 2003 shows that bioactive components help with hippocampal synaptic deficits in PTSD by activating the kappa-PKA signaling. Crystal et al. 2017 highlight ketamine's potential for treating synaptic loss in PTSD due to its rapid effects, though further research is needed. Neuroplasticity is the brain's ability to adapt by forming new connections and eliminating unused ones. It's crucial for learning, memory, and recovery. Pavrik et al. 2003. Evidence-based treatments like trauma-focused cognitive-behavioural therapy and eye movement desensitization and reprocessing are recommended for PTSD. UK Psychological Trauma Society 2017. These therapies rewire neural pathways, reduce fear circuit overactivity, and improve prefrontal cortex function. Cohen et al. 2006. Sharpio 2001. Therapies like neurofeedback and transcranial magnetic stimulation, TMS, can alter brain activity. Neurofeedback trains individuals to regulate brain function, while TMS uses magnetic field to stimulate specific brain areas. Hammond 2011. Mindfulness-based stress reduction uses mindfulness meditation and yoga to mitigate trauma, supporting emotional regulation and cognitive processing. Kabat-Zinn 1990. Grounding therapy reconnects individuals with the present moment, and walking therapy in nature setting relieves anxiety and depression. Porges 2011 and Berman et al. 2012. Music therapy reduces stress hormones and promotes relaxation by increasing dopamine release. Clout 2005. Case study: Impact of police victim blaming on C-PTSD and neuroplasticity. According to PTSD UK, between 51% and 75% of women who experience intimate partner violence develop PTSD. When authorities such as the police cannot provide support and validation, it can exacerbate the trauma and significantly increase the likelihood of developing C-PTSD. Re-traumatization occurs when individuals are exposed to repeated traumatic events, exacerbating existing symptoms and further altering brain structure and function. This can lead to an impact on neuroplasticity. Victim blaming shifts responsibility to the victims, exacerbating their trauma and leading to feelings of shame, guilt, and isolation. This dynamic discourages victims from seeking help, which can entrench the cycle of abuse and contribute to the development of complex post-traumatic stress disorder. Understanding this harmful impact is crucial for fostering a supportive environment that encourages healing and recovery. Without treatment, the brain's maladaptive changes can become more entrenched, leading to persistent symptoms such as flashbacks, anxiety, and emotional dysregulation. He et al. 2018. Additionally, chronic stress and untreated PTSD can significantly elevate the risk of suicide. Crystal et al. 2017. Addressing these issues through appropriate interventions is crucial for preventing these severe outcomes. Future research in C-PTSD should integrate neuroimaging and neuroplasticity study to enhance understanding and treatment. Techniques like MRI and fMRI can observe brain changes, aiding in the diagnosis and targeted treatments. PTSD UK 2023. Neuroplasticity, the brain's ability to reorganize is key in therapies like EMDR and CBT, which rewire the maladaptive pathways to reduce symptoms. Sharpio 2001. Combining these approaches can provide a comprehensive view of trauma's impact and therapeutic recovery.